Chapter 4, Outpatient Clinics, Primary and Specialty Care, by Deanna R. Willis. This chapter makes the prospects of operating a primary care outpatient clinic in the USA sound horrible. It is a high-volume, low-margin part of healthcare with surprisingly few mechanisms to be able to recover costs for additional services provided to patients, such as coordinated care or downstream revenue. Outpatient specialty clinics may be slightly better as they have higher margins, but overall, this seems like a tough business to be in. This chapter offers a very brief overview of outpatient care, the two major types of outpatient clinics, both office-based and hospital-based, some of the overhead expenses, and a few different payment models. It's a cursory review at best. Most outpatient clinics operate based on a fee-for-service, face-to-face encounter model. In 2005, it was estimated that there was 963 million office visits in the United States, approximately 3.1 visits per person. Primary care, being defined as family medicine, general internal medicine, general pediatrics, and obstetrics and gynecology, comprised 60% of visits, and the other 40% were surgical and subspecialty medicine, with the split 50-50 between surgery and medicine. Most outpatient visits occurred in metropolitan areas, whereas rural areas had less visits per person. And the thought was that perhaps rural physicians either provide more services in a single visit encounter, non-metropolitan patients travel to the cities for their care, or potentially rural patients through cultural reasons visit the physician less. Of all office visits, 53% were for chronic health conditions, with hypertension accounting for 1/4 of visits, and since 1995 it has been the leading cause of outpatient visits. For those under age 21, the most common visit type was a routine child health check. There are two general structures to outpatient medical clinic ownership: office-based and hospital-based. Office-based practices are typically owned by physician groups who collect fees from their professional services provided to patients, as well as fees for technical procedures or any ancillary tests the clinic provides, such as an X-rays or laboratory. The chapter suggests that one of the major downsides of office-based clinic practices is that many services don't have billable codes, and it's difficult to capture downstream revenue. For instance, if a licensed practical nurse checks a patient's blood pressure, this may not be a billable service, and they may require a face-to-face physician encounter to be able to bill. There is also the trouble with downstream revenue. If a surgeon evaluates a patient in their clinic and then the operation happens in a different hospital down the road, it's the hospital and the operating room which will be recuperating the majority of the profit from this care encounter, not the actual clinician visit. And so the book says, thus, it is generally considered difficult in today's healthcare market to have an independent office-based practice that is financially successful unless a significant number of procedures or ancillary tests are performed at the clinic. Which leads to the second type of office-based practice, hospital-based. These are clinics which are associated with a hospital, and so not only do they charge professional fees, but also a facility fee, which is billable because it's allegedly occurring at a hospital. Though in reality, these are clinics which are not physically associated often with a hospital, but more on paper associated with the hospital. These clinics are able to capture revenue not just from professional fees and facility fees, but also if a patient ultimately requires a higher level of intervention or surgery, those patients will come into the hospital's network. If you're interested in facility fees, the book American Sickness by Elizabeth Rosenthal is an excellent read. The largest expense that outpatient clinics have is salaries. Organizations such as the Medical Group Management Association publish tables with proposed optimal numbers of support staff per full-time equivalent physician. Staffing clinics with support work is difficult. There is often not surplus or extra workers available in a clinic, which means that the absence of a single support staff member can dramatically affect the clinic's function that day. Longer-term absences may be filled by temporary agency workers, but the skill level is variable and training is still required. With regards to revenue and payment services in outpatient medicine, like all of American healthcare, the fees are remarkably uncertain. Typically, patients don't know what the fee will be until the time of service, and it's unclear to them usually how much of this fee will be covered by their insurance provider. Clinics focus on a concept of payer mix and relative value units. The payer mix is both the mix of the insurance companies providing reimbursement as well as the types of services being provided. Ensuring diversity of payer mix ensures that a single insurance company cannot have too much leverage over the clinic's function, and there is, of course, financial incentive to minimize the number of low reimbursement services. The concept of a relative value unit is the weighing of each medical service or procedure incorporated into the clinic's total expenses, including things such as equipment as well as malpractice insurance to provide that unit of service. The ability to apply relative value units to the type of work each clinician is doing enables clinics to compare the relative productivity of different physicians. In order to reimburse clinicians and clinics more appropriately based off of performing high-value care, the concept of pay for performance, P4P, was introduced. Although it sounds good in concept, a lot of pay for performance incentives are based strictly on administrative data sets. This means that reimbursement may be for performing an A1C to test someone's blood sugar level, but not actually knowing what the level is or if the patient is controlled. There are new hybrid methodologies, pay for performance, which include both clinical data as well as administrative level data, in the hope that the incentives can be more closely tied to better clinical outcomes. Unfortunately, there remains little incentive for care coordination. Primary care clinics have very low margins, and therefore hiring additional staff to coordinate care for patients would be difficult. The exception is if a primary care clinic is associated with a hospital, and there could be the potential to increase the hospital-based services through the use of care coordinators. Specialty clinics with their higher margins have used nurse practitioners to coordinate care, but this is typically restricted to single disease or single condition. Insurance companies are introducing case management services with the hope to coordinate patients who require multiple services care. And looking into the future, we know that there's currently not enough primary care physicians, and the shortage is anticipated to get worse, both with the declining number of medical students interested in pursuing primary care, as well as the growing number of elderly populations. Outpatient and primary care is an area ripe for disruption, and I think this will be the primary focus on the new Amazon, Berkshire, and JP Morgan venture, as well as the Apple Health ventures, which we see forming here in 2017-2018. There's also been lots of good movement in the space from direct pay clinics and new startups trying to rethink the primary care experience, which will be discussion for a different post.